Acute baronychia. Acute baronychia is acute infection in the nail fold. It is the commonest hand infection, usually due to trimming of a skin tag around the nail, or it may be due to unsterile instrument of a manicurist. Clinically, there is pain, tenderness, and swelling in the nail fold, especially maximum at the angle of the nail fold. If this is the nail fold, there are two angles, angle here and angle here, between the vertical and the horizontal part of the nail fold. Usually, if the condition is neglected, the condition passing to pointing of pus, and if neglected, rupture of the abscess and discharging pus. What is the treatment of acute baronychia? The treatment is incision and drainage once pus is formed, and the main manifestation of pus formation is throbbing pain. Anesthesia is ring anesthesia in the root of the nail, in the root of the finger, without adrenaline, and incision by one of the following methods. The first is a fine tipped scalpel is introduced between the nail and the nail fold to raise the nail fold and to incise the skin cap through which pus point, like this. Fine tipped scalpel introduced between the nail and the nail fold to raise the nail fold and to incise the skin cap over the pus. Or if pus is collected here in the angle of the nail fold, and this is very common, oblique incision or excision of a triangular part of the skin at the angle of the nail fold. Oblique incision or excision of a triangular part of skin at the angle of the nail fold. If pus extends below the root of the nail, this is the root of the nail, and the pus spread deep to the root of the nail, this indication for 2. Oblique incision at the angle of the nail fold, raising the skin flap in between the two incisions, like that, and excision of the related part of the nail to drain the underlying pus. If the nail is floating nail, the nail is floating nail due to pus under the nail, this indication for removal of the nail to drain the underlying pus. This is the commonest hand infection, which is called acute baronychia. The next common hand infection is phelon. Phelon is infection in the bulb space. What is the bulb space? The bulb space is the subcutaneous space in front of the terminal phalanges. This space is closed space, separated from the distal volar space. This is called the space in front of the middle phalanx is called distal volar space, and the space in front of the proximal phalanx is called the proximal volar space, and the space in front of the terminal phalanx is called the bulb space. Proximal volar, distal volar, and the bulb space. The bulb space is closed and separated from the distal volar space by the interphalangeal crease. By the interphalangeal crease, and closed on both sides and distally by a fibrous septum extend from the bone. This is a cut section in the distal phalanx. From the distal phalanx to the skin passing a fibrous septum, and this fibrous septum closes the bulb space from the sides and distally. Fibrous band pass from the distal phalanx to the skin distally and on both sides. And proximally, we are separated from the distal volar space by the interphalangeal crease. This space is a closed space containing fat and digital artery. This digital artery gives branch. This is a digital artery, and this is a tendon of flexor digitorum profundus. Therefore, the bulb space containing fat, digital artery, and tendon, which is the tendon of flexor digitorum profundus. The digital artery passes in the finger, while the digital artery passing in the distal volar space gives a branch to the proximal part of the distal phalanx. Then the digital artery passes to the bulb space, where it gives the branches to the distal part of the distal phalanx. This is very important. Why? Infection in the bulb space will lead to compression of the digital artery and the interference with the blood supply of the distal part of the distal phalanx only. Distal part only, because the distal part take its blood supply from the digital artery in the bulb. The proximal part of the distal phalanx is not affected. Why? Because it takes its blood supply from the digital artery before the digital artery enters the bulb, while the digital artery passing in the distal volar space. The bulb space is divided by many fibrous septa into loculi. These fibrous septa passing from the distal phalanx to the skin, dividing the bulb space into many loculi and compartments. What is the incidence of bulb space infection? Bulb space infection is the second common hand infection. Etiology as usual, as the general principle. Usually puncture, pinprick in the bulb. Pathologically, there is diffuse congestion and edema and swelling in the bulb. The bulb is a very small closed space, leading to high pressure inside the bulb, and high pressure inside the bulb, leading to rapid pus formation. The infection early may be localized to one compartment of the bulb, but if the condition is neglected, usually the infection is spread to all compartments in the bulb and the affection of the bulb diffusely. Complication first of all, ischemia and necrosis of the distal part of the distal pharynx due to compression and thrombosis of the digital artery in the bulb. And we said before that the proximal part of the distal pharynx is not affected because it derives its blood supply from the digital artery before the digital artery enters the bulb. Necrosis of the distal part of the distal pharynx leading to parrot beak deformity of the finger due to sequestration of the distal part of the distal pharynx. Also, sequestration of the distal pharynx may occur due to spread of infection to the bone, osteomyelitis of the distal pharynx, and spread of infection to the tendon and the surrounding synovial sheath, leading to what is called tenosynovitis. Spread of infection to the distal interphalangeal joint, leading to septic arthritis. What is the clinical picture of bulb space infection? Sure, there is pain, tenderness, and swelling over the bulb. What is the treatment of bulb space infection? As baronychia, once throbbing pain, ring anesthesia in the base of the finger or the root of the finger without adrenaline. And according to the severity of infection, if the infection is localized to one compartment, vertical incision over the maximum point of pain and tenderness to drain this small amount of pus. If localized like this, localized to one compartment, but if there is affection of the whole the bulb, this need to and diffuse pus formation in the whole the bulb, this need anterolateral incision. Anterolateral incision in the distal 2/3 of the bulb. Anterolateral incision. This is the anterolateral incision in the distal 2/3 of the bulb, and by scalpel we enter in this incision to divide all loculi and drain all pus. Why the incision anterolaterally in the distal 2/3 of the bulb only? Because if you extend this incision to the proximal part of the bulb, here the insertion of the flexor tendon, and this lead to injury of this flexor tendon, which is the tendon of flexor digitorum profundus. In severe conditions, we make incision on the right side and a counter incision corresponding to the first incision on the left side. If there is severe conditions, therefore, affection of one compartment, vertical incision over the affected area over the maximum point of pain and tenderness. Diffuse infection في البulb, anterolateral incision in the side of the distal 2/3 of the bulb, and the condition is very, very severe, counter incision on the other side. This is the bulb space infection, and this is the variable incisions according to the severity. The next infection is web space infection. Web space infection, what is the web? There are 3 web spaces related to the medial 4 fingers. 3 web spaces related to the medial 4 fingers. Each space is wedge in shape. This is the black area is the web space, which is wedge in shape, which has a base at the free edge of the web. This is the free edge of the web. This is the base of the wedge and has apex. Where is the apex? The apex at the metacarpophalangeal joints. This is the metacarpal bone and this is the proximal phalanx, and this joint is called the metacarpophalangeal. The apex related to the 2 related metacarpophalangeal joints. The web space is limited anteriorly and posteriorly by what? By the skin of the web. And on both sides, palpate the web space and tell me what is related to the both sides. The proximal on 2 sides, these bones, which are the proximal phalanges. Proximal phalanges. And sure, in front of the proximal phalanges, there is the proximal volar spaces. Therefore, each web is connected with the related 2 proximal volar spaces. Each space containing fat and important muscle called lumbrical muscle. The lumbrical muscle originates here in the hand in a space called mid-palmar space. And this is lumbrical pass then in the web space to be inserted in the back of the proximal phalanges. Therefore, lumbricals related to mid-palmar space and the senar space proximally and the web space distally. Therefore, infection from the web can spread proximally to the mid-palmar space or to the senar space. What is the etiology of this condition? As usual, usually puncture wound. Puncture wound in one of the web leading to infection. And the infection may spread along the lumbrical proximally to the mid-palmar space or distally to the proximal volar space. What is the clinical picture? This is web space infection. The space between the fingers. 3 web spaces in between the medial 4 fingers. What is the clinical picture? Pain, tenderness, swelling over the web, and inflammation usually spread to the related proximal volar spaces. And if the condition is neglected, the infection becomes spreading to the middle of the palm in the mid-palmar space. Look for all cases the distance between the related 2 fingers. This is the space between little and ring finger. This is the space between the ring and middle finger. Is the same space like the 2 fingers related to this infection? There is very important finding in web space infection. There is separation of the 2 fingers related to the infection, like this. Look for the spaces here, and the 2 fingers becomes separated like this. The two fingers are separated. What is treatment of this condition? Very simple. Longitudinal incision on the dorsal aspect of the whip over the most tender point. This longitudinal incision over the dorsal part of the whip for the skin only. Then enter by closed sinus forceps and open the sinus forceps inside the whip. This is the famous method which is called Hilton's method. And in Hilton's method, we open the sinus forceps inside the whip longitudinally. All important structures in the hand passing longitudinally, and any incision in the depths of the hand should be longitudinal to avoid injury of the important longitudinal structure. This is the acute paronychia, bulb space infection, and web space infection. Thank you for good listening and good luck.